So for the next session, the chairperson is Dr. Pari Vijayaraghavan, who's currently at Powai Medical College Hospital in Coimbatore, and the speaker is Dr. R.V. Raghavendra Rao, who's at the Renova National Institute of Gastroenterology and Liver Diseases. Over to you, Pari.
Thank you, sir. I know dinner time is looming large upon the audience, and we are running late, so it won't take much time. I just wanted to say that this is liver transplantation is probably mother of all surgeries, which is going to be performed on one of the most unfit patients. So how best to go about it? What are the nuances in working up these patients to make sure that it's a success? That's what I think my good friend Dr. Raghavendra Rao is going to touch upon, and it's over to you, sir. Yeah, Dr. Raghu, you can go ahead. Dr. Raghavendra Rao?
Yeah. Yes.
You can make it full screen.
Yeah. So, thank you very much, Professor Kapoor and the Jaipur Surgical Society for inviting me for this talk. And having covered...
Can you please make it a slideshow? Just click on the slideshow.
Yeah,
that's good.
So basically I'll be covering the next 15 minutes of the recipient workup as pre-transplantation evaluation of the liver recipients under these categories of psychiatric assessment, cardiac evaluation, renal function evaluation, infectious diseases, nutritional assessment, which is very, very important, mostly neglected in a majority of the cases. Radiological evaluation, of course, as part of the regular workup. Very important to have proper psychiatric interview, as is being stressed for donor evaluation by the previous speakers and the chairpersons. Similar workup and psychiatric interview for the recipient, where the patient's reaction, what is his take on the problem he has at hand, that is the end stage of the disease, the knowledge about the transplantation, and how compliant he was in the previous treatments whenever he was admitted with the treatment protocol and the advice which is given by the healthcare professionals. Acceptance of post-transplant medical regime, which he really understands or not, and the need for the daily immunosuppressive drugs and the regular medical follow-up, which is very, very important for the success, long-term success of these transplants, and how the family is taking up this process of is definitely a burden on the family, a stressful situation, how the family is reacting to the news of the transplantation. Of course, part of the interview covers very important, particularly in India and South Asia, which is missed, is the etiological factor, which is alcohol, which as stressed by Professor Saraswat and Shalin. It is a very important cause of etiological factor for end-stage liver disease in India. Illicit substance history, nicotine usage, which can affect the post-operative outcomes, past psychiatric history and developmental history, and mental status examination is very important. Alcohol abuse and the risk of its relapse is very important to us before taking up the patient for a transplantation. Next very important factor which needs to be understood is the cardiac evaluation. Why is it important? Because there are various situations which can arise during and after transplantation, liver transplantation, like events leading to severe hemodynamic stress and compromised cardiac function. Like preload reduction is a very important issue during the transplantation, particularly because of the massive blood loss and sometimes requirement for IVC cross-clamping. Rapid increase in preload during reperfusion, leading to post-reperfusion syndromes, which can include hypotension, myocardial depression, and rhythm abnormalities. Increase in the afterload, particularly if there are rare situations of aortic clamping for reconstruction. Acute acidosis, hyperkalemia, hypothermia, which can arise during reperfusion, which can lead to cardiac stress. Hypocalcemia in the citrated blood products, particularly after massive blood transfusion, can put acute stress on the heart function. So basically, we need to look at the coronary artery disease, presence or absence of heart failure, both systolic and diastolic. Portopulmonary hypertension is very specific factor which needs to be evaluated, which needs to be addressed before transplantation in these cirrhotic patients. Arrhythmias, of course, dilated cardiomyopathy induced by cirrhosis, cirrhotic cardiomyopathy, and particularly if the etiological factor is background disease of hemochromatosis, sarcoidosis, amyloidosis is there, a part of the disease process can also lead to infiltrative cardiomyopathy, which can compromise the cardiac function. History of smoking, hypertension, diabetes, cardiac illness, family history of premature coronary artery disease, hyperlipidemias, diabetes, obesity, and NASH. These can affect the cardiac function. And the way to evaluate with the basic parameters like basic evaluation like ECG can address, can give us information regarding lot of changes, particularly coronary artery disease, axis deviations, bundle branch blocks, and indication about cirrhotic cardiomyopathy. Of course, the next step of evaluation will be a 2D echo, which is done for majority of the problematic cases, and ejection fraction evaluation, motion wall abnormalities, valvular abnormalities, and these factors can really be assessed very well by a good cardiologist on 2D echo. Bubble contrast is a very specific tool in identifying hepatopulmonary syndrome in cirrhotic patients. So apart from routine evaluation, bubble contrast echo is a very important parameter to be addressed. Stress testing is a very important parameter, particularly with the TMT test or dobutamine stress echo is a very important tool for assessing the cardiac function in cirrhotic patients. And the myocardial perfusion scintigraphy may be indicated in some of these patients before going on for angiogram, coronary angiogram. Coronary angiogram is very useful tool, particularly if you have a positive stress test in the recipient. But when you are having a LV dysfunction or a LV function of less than 40% on 2D echo, and a patient is above 60 years of age, or any patient with long-standing diabetes, particularly which is involving the end organs like nephropathy and retinopathy. Right heart catheterization is useful tool, particularly in assessment of portopulmonary hypertension. RVS, right ventricular systolic pressure of more than 40 on 2D echo can be a good indicator to take up the patient for right heart catheterization to assess the portopulmonary syndrome. And also, right heart catheterization is studied to measure pressures in the both right atrium and also right ventricle, pulmonary artery, and pulmonary capillary bed pressure. Basically, pre-transplant cardiac evaluation, this is a busy slide, but you can see from the basic evaluation of physical and history examination, electrocardiogram and echocardiogram, you can come to a reasonable appreciation of the status of the cardiac status of the patient. And if there is normal on evaluation and the age of the recipient is more than 40 years, risk factors of CAD are not there, you can directly go for transplantation. If any one of these changes are there, then you escalate your evaluation to the next level of stress testing by treadmill test or dobutamine stress echo, or if any one of these factors are suggestive of a less ejection fraction of less than 40%, wall motion abnormalities, then you may consider coronary angiogram, or if there is any indication of right heart pressure increase or RVSP of more than 40, you go for right heart catheterization. Portopulmonary hypertension is a very important parameter to be assessed in preoperative evaluation of these recipients. Common presentation, you can assess fatigue, external dyspnea, exertional dyspnea, syncope, chest pain, sudden death. Fatigue is very common in cirrhotic patients, but if it is associated with any one of these SOB or exertional dyspnea, then you suspect portopulmonary hypertension and evaluate it by measuring the mean pulmonary artery wedge pressure, mean pulmonary artery pressure. If it is more than 25, you label them as portopulmonary hypertension. So depending on the type of the patient and the mean pulmonary arterial pressure, you go for further evaluation and you reject or take up the patient for transplantation. For example, if the mean pulmonary arterial pressure is less than 35, PVR is less than 240, and good QT and right ventricular function, then go for transplantation. If any one of these parameters are not favorable, then you go for further evaluation and assess the patients. If he has poor ventricular function, then
What's going on?
if the ventricular function is reasonable, then you go for transplantation. Similar to portopulmonary hypertension, there is one more parameter which is related to cirrhosis, which can affect the oxygenation in the blood, which is hepatopulmonary syndrome. HPS is basically defined as a triad of liver disease, increased alveolar arterial oxygen gradient in the presence of intrapulmonary vascular dilatation. This is a very important definition to understand. And you suspect basically any patient with cirrhosis with hepatopulmonary syndrome on your basic ABG, arterial blood gas analysis. If there is arterial hypoxemia, then you do suspect hepatopulmonary syndrome in these patients and make a positive effort to diagnose or reject the case as hepatopulmonary syndrome. A suspected HPS patients are those patients with cirrhosis who have cyanosis, clubbing, orthodeoxia, and also platypnea. These are the patients who require further evaluation other than the ABG in the form of confirmation of HPS by a bubble contrast echo, which I mentioned previously, is a very, very useful tool in assessing the severity of the hepatopulmonary syndrome and also the shunt fraction. So next important parameter apart from the cardiac evaluation and pulmonary evaluation is the renal function, which is basically can be of different types in cirrhotic patient. It can be in the form of an acute kidney injury, which is usually reversible, a background chronic kidney injury. It can be acute on chronic kidney disease or end-stage renal disease. So basically, challenges in estimating renal dysfunction do arise in cirrhotic patients because of the reduced muscle mass. The 24-hour creatinine clearance overestimates the GFR, which is generally, it's more than 30% overestimate of the creatinine clearance will be there in these cirrhotic patients. High bilirubin levels do affect the lab assessment of serum creatinine, and the gold standard for GFR measurement is either inulin or ioxazole clearance test. Cystatin C can be an alternative, but it is not very dependent because it is not very dependent on the muscle mass or serum bilirubin levels. But these are all not routinely available for regular evaluation of renal function in cirrhotic patients. So basic evaluation includes renal evaluation for liver transplant candidates includes electrolytes, blood glucose levels, urea nitrogen, creatinine, arterial blood gas, urine analysis, urine sodium, spot sodium protein, 24-hour urine measurements, and also GFRs measured by either isotopes and ultrasound of the kidneys, and kidney biopsy is very rarely required if you are suspecting CKD. So acute kidney injury is basically rise in serum creatinine of more than 50% from baseline, or a serial estimate of serum creatinine showing more than 0.3 milligrams per deciliter rise in 48 hours. So HRS type 1 is a specific form of acute kidney injury, which is mostly recoverable. Chronic kidney injury can be a problem if the GFR is less than 60 ml per minute for more than 3 minutes. And HRS type 2 is a form of CKD, which is a common presentation in some of these cirrhotic patients. Acute and chronic kidney injury can be a problem if there is a rise in serum creatinine of more than 50% from baseline, then you suspect acute and chronic kidney disease. What is very important is identifying the associated renal diseases in cirrhotic patients. For example, hepatitis C is very commonly associated with membranous proliferative glomerulonephritis or fibrillary glomerulonephritis. Similarly, some of these patients with alpha-1 antitrypsin deficiency or primary biliary cirrhosis can have association with either IgA nephropathy or membranous nephropathy. So it is very important to identify, particularly when you are dealing with a cirrhotic patient with hepatitis C virus, which is a common association with renal disease with cirrhosis. Of course, any patient who is undergoing liver transplantation will have a basic radiological evaluation, including ultrasound, CECT, and some of these cases we also do MRCP, not mandatory, but yes, it may be required. Portal vein thrombosis and in cases of PVT, studying carefully the location of the shunts, their diameter, the assessment of the other veins, other mesenteric vasculature, for example, the SMV and the splenic vein assessment, looking for the hepatic venous thrombosis, arterial anatomy, looking for celiac artery stenosis, replaced hepatic arteries, and any unsuspected malignancies or abdominal tuberculosis. These are common issues to be evaluated in the radiological evaluation. Chest, of course, needs evaluation for pneumonia, effusions in these patients, MRI brain in elderly patients to rule out any chronic SDH or AVM. Nutritional assessment is a very, very important parameter. Some of these patients are very prone for sarcopenia. Body weight may be affected by ascites, edema, and diuretics. Though they weigh normal, the weight may be normal, their muscle mass is very low, and some of these are really sarcopenic. Anthropometric measurements are of questionable sensitivity. Nitrogen balance studies are affected because of the background renal dysfunction. Total protein, albumin, may not be helpful, though pre-albumin can sometimes be of good assessment value for assessing the nutritional status. Subjective global assessment is a method based on patient history, examination, and existing condition. It is a validated procedure. It is found to be a reliable tool in assessing the nutritional status. This is a quick reference guide for subjective global assessment, which includes the history, physical examination, existing condition, nutritional rating based on the results of the history, physical examination, and existing conditions. So you can grade the patients as either they are well-nourished or moderately nourished or severely malnourished patients. And depending on that, you can plan your pre-transplantation nutritional replacement. Very important, because a very important parameter is evaluation of infectious diseases, because these are prone to be resurfacing in the post-transplant period because of the immunosuppression. So basically viral infections, bacterial infections, fungal infections, latent infections, particularly tuberculosis, which is a very important problem in India. And evaluation includes various serological tests or NAT assays, for hepatitis B, C, D, and HIV, and also CMV, EBV, and these things need to be evaluated. And this is basic evaluation of infectious diseases in cirrhotic patients. So special emphasis should be given on immunization history, particularly with this past pandemic. Everybody is insisted on to have COVID vaccination. Previous episodes of spontaneous bacterial peritonitis, previous episodes of bacterial cholangitis, travel history, residence of areas in endemic areas, and various screening studies, tuberculosis skin tests may be indicated in some of these patients, and serological studies for, as I mentioned previously, various viruses including CMV, EBV, and varicella zoster virus. So in summary, holistic preoperative proper evaluation is essential for transplantation success. This should include starting from psychiatric assessment, nutrition, covering the nutritional assessment, various organ functions like cardiac, renal, and parameters, and also a proper nutritional evaluation. Subjective and objective methods are useful for different parameters. It need not definitely only be based on objective criteria or lab studies. It can even include proper history taking, physical examination. These are all done by the properly trained people, and these subjective parameters can be a very, very useful tool in assessing the preoperative assessment of the cirrhotic patients for fitness for surgery. Standardized terminology and risk assessment will help in proper preoperative optimization of these patients, give us time to optimize these cirrhotic patients and help in listing these patients for transplantation. Thank you so much.
Yeah.
Pari.
Yeah, fantastic talk, Dr. Raghavendra. And we are just 4 minutes past 9. And sir, can we take like 5-10 minutes
let's take
before we wrap it?
Questions
Yeah,
in
fine.
the chat. Raghu, you can take the questions in the chat
Yeah.
directly.
So Dr. Yashir Khan, I guess the gentleman from Pakistan, his question is any experience with the use of sildenafil or ileopros for portopulmonary hypertension? Dr. Raghu?
Yeah. Sildenafil, yes, it can be used when the for 12 weeks course of therapy can stabilize these patients with mild or moderate portopulmonary hypertension, but not very useful in patients with severe portopulmonary hypertension. Even those patients who undergo this therapy needs to be quickly evaluated and reassessed after the therapy and taken up for transplantation.
All right. So the next question is from Dr. Shashwat. The patient requires an angioplasty after an abnormal coronary angiogram. What is the time period after which a transplant can be offered?
So if the angiogram is normal, if the angiogram...
the abnormal angiogram
needs angioplasty, generally we cannot offer the transplantation for at least 6 months before, because these patients who undergo angioplasty, the antiplatelets, the dual antiplatelets which they are put on, cannot be withdrawn for at least for a period of 6 months.
Yeah, can I just make my own comment, Dr. Raghu?
Yeah.
So I guess what we got to tell our cardiology colleagues is that in case you have to stent him, kindly don't use the drug-eluting stents, because as Dr. Raghu was mentioning, drug-eluting stents require longer period of antiplatelets, especially maybe 2 antiplatelets. So you can request them to use non-drug-eluting stents, which at 3 months mostly you can withdraw them from antiplatelets and go ahead with surgery. So you guys, we have to talk with the cardiology what the plan is. All right, that's a good question. And next question is, when does hepatopulmonary syndrome considered a contraindication for liver transplantation?
Hepatopulmonary syndrome with ABG showing a PaO2 of less than 50 is considered to be severe hepatopulmonary syndrome and is a absolute contraindication for liver transplantation.
Right. Okay. Again, one more question from Dr. Yash. What is the recommendation regarding alcohol abstinence?
Alcohol abstinence generally is recommended to be 6 months, but see, we have to properly look at the etiological factor, whether alcohol social drinking is the real reason, or is it the alcohol is the true etiological factor? Is it just a social drinking? So if alcohol is the etiological factor, if the patient is well motivated, family understands, and the patient understands the implications of the alcohol abuse, then a 3 months period is enough.
Yeah. So the short answer is no. The general consensus is the alcohol abstinence of 3 months, not the 6 months anymore, and obviously with good social support and rehabilitation. So I guess next question is
question from Kamaljeet.
HCV RNA does not disappear with treatment. At what levels do you still proceed with LDLT?
Pardon?
HCV. We got a patient with HCV. Yeah. I guess he has been treated with the directly acting agents, and RNA does not disappear.
Yeah.
At what levels do you proceed with LDLT?
So if the value, if the mRNA, the RNA values are low log values, then even if the HCV treatment is ineffective, so with the currently available treatment protocols, you can still proceed with liver transplantation and restart the treatment in the post-operative period.
Right. Fantastic. Any more questions? If there are, I don't see any more questions from the audience, in which case I have a few questions or comments from myself. So Dr. Raghu, you mentioned in detail about the infectious workup. I guess one more thing which is more important in our setting is antibiotic abuse. Most of our patients have had antibiotic courses over a period of several years or months, and in our setup we see a lot of antibiotic, the bugs resistant to even carbapenems. So I guess one of the important things is to see what is the prevailing pattern of their antibiotic resistance. And if the patient is already having a carbapenem resistance pattern in the pre-transplant period, it's very important to notice that. And we usually give a period of prebiotics and probiotics, and we do a stool testing for CREs, carbapenem resistant enterobacteriaceae. And if we still have a CRE, then this patient is higher risk for developing postoperative infection with CREs. That is one thing which I thought we usually do, and I thought probably I would mention that. Other thing is, you talked in detail about nutritional assessment. That's, I think, the most important aspect of preoperative workup. We have something called now prehabilitation, just like rehabilitation. It's called prehabilitation, where we give a lot of importance to nutrition and rehabilitation, like physiotherapy. So nowadays we start using objective assessment of nutrition, which in which case the CT comes very handy. The bulk or the thickness of the psoas muscle and abdominal wall muscles is a very, very good indicator of the ongoing nutritional status of the patient. So I guess nowadays that is being more and more used. So anyway, these patients get a CT scan for abdomen evaluation, and we also have to look at the abdominal wall musculature, especially psoas and the posterior abdominal wall muscles. And more we started using the ultrasonography for the muscle. So muscle ultrasonography is the other thing which is coming up in a big way for assessing the nutrition in these patients. We do ultrasonography of the thigh muscles to assess the nutrition status. That is other thing which is coming up, probably worth noting. And renal evaluation, you touched in great detail. I just wanted to ask you, do you guys do DTPA renogram? Because as we know, creatinine is not very useful, and cystatin C is not widely done. In case you need to know the exact nutrition, renal status, we do DTPA renogram to assess the GFR. What is your practice in your center? Do you guys do DTPA renogram?
Very, very selective patients, particularly if there is some background obstructive renopathy or background CKD, then we do the nuclear scan. Otherwise, not a routine parameter. Yes.
Yeah, because post-transplant, the GFR is expected to come down by almost 30% because of the stress of the surgery as well as usage of renotoxic agents like tacrolimus. The patients are supposed to have you can expect the patient's GFR to come down by 30%. So it's always a good idea to know what is the baseline GFR of these patients. So is there any more questions?
One question on pulmonary tuberculosis.
How do you approach a recipient with pulmonary TB?
Yeah. See, it's a very difficult situation, patient with active pulmonary tuberculosis. So generally we start off these patients with modified ATT, avoiding and taking care of the nutrition. Nutrition parameters are very important in these patients. So modify ATT for at least a month, and then reassess the patient for active infection, and then take up the patients for transplantation.
Very
end-stage liver disease patient.
Yeah, very well said. Right. Sir, it's 9:13 and
I think we'll close. So thank you, Pari. Thank you, Raghu. Thank you very much. And I see Avinash probably also is logged in. I would like to thank Avinash and his team for providing the technical support, not only for this masterclass, but for all the Jaipur surgical tutorial sessions. So for the participants who are still there, I have been putting up notices about Jaipur surgical tutorial. If you want to join, please send a WhatsApp message to my colleague, Dr. Anand Nagar. His number is there. And the third Jaipur Surgical Festival, 1st to 3rd December. The theme is we have launched an international study group on of gallbladder cancer, just as ISGPS. And the topic which will be discussed is incidental gallbladder cancer. Work has already started. More than 60 content contributors have already contributed content related to different aspects of incidental gallbladder cancer. We've identified about 15 national and about 50 international experts. Many of them will be coming physically to Jaipur. And at that meeting, all these presentations will be made, and then a consensus statement will be kind of authored by all the participants. So tomorrow we meet again at 7 o'clock to cover the rest of the 4 topics. Thank you. Thank you once again, everyone, all the faculty, all the attendees. Thank you very much.
Thank you.
We'll close the session.